Your skin might be showing signs of disease years before you feel anything inside. In fact, many serious conditions first appear on the skin, not in pain, not in blood tests, not in obvious symptoms. Sometimes the skin is a window into what is happening internally. That's what I will tell you, 7 skin problems that can indicate internal organ damage. The first sign is spider angioma. And a spider angioma can be a sign of cirrhosis or chronic liver damage. It happens because when the liver is damaged, it cannot properly metabolize estrogens, the so-called female hormones. As estrogen levels rise, they cause dilation of small arterioles, stimulate angiogenesis, and promote the formation of new superficial blood vessels. As a result, you see one central arteriole with thin radiating capillaries spreading outward, like a spider, like a web, like a vascular star. They are especially common in men with cirrhosis because elevated estrogen activity in males is abnormal and more clinically significant. They are most often located on the chest, face, and shoulders, and if a person has more than 5 spider angiomas, this strongly correlates with chronic liver disease, particularly cirrhosis. Now the important question: how often is this harmless, and how often does it truly indicate disease? In the general population, a single spider angioma is relatively common. Studies show that up to 10 to 15% of healthy adults may have one lesion, especially young women. The second sign is xanthelasma. Xanthelasma appears as soft, flat, yellow plaques around the eyelids, usually symmetrical, painless, and slowly progressive. It is not a pimple, not simple fat under the skin, not a superficial blemish. These are cholesterol deposits within the dermis. When similar cholesterol deposits appear in other areas of the body, they are not called xanthelasma. In general, they are called xanthomas, cutaneous cholesterol deposition. This happens when blood cholesterol is elevated, especially when low-density lipoprotein cholesterol, the so-called bad cholesterol, is significantly increased. Immune cells, particularly macrophages, absorb this excess cholesterol, become lipid-laden, circulate, and eventually deposit in tissues. Because the eyelid skin is thin, highly vascular, and metabolically active, these cholesterol-laden cells often accumulate there, visible, detectable, unmistakable. Xanthelasma is more common after the age of 40, especially in people with hyperlipidemia, in patients with liver disease, and in those with hypothyroidism. If it appears in a young person under 40, it raises strong suspicion for familial hypercholesterolemia, a genetic disorder with markedly elevated low-density lipoprotein cholesterol and a significantly increased risk of premature cardiovascular disease. In older adults with only mild cholesterol elevation, xanthelasma can still appear. In such cases, it is not always catastrophic, not always dangerous, not always urgent. Third important skin and body manifestation is gynecomastia, the enlargement of the male breast. Gynecomastia is not just fat, not just muscle, not just weight gain. It is true enlargement of male breast glandular tissue. Normally, the male breast remains small because testosterone suppresses breast tissue growth. But when the estrogen to testosterone ratio rises, not necessarily absolute estrogen levels, but the balance, the ratio, the hormonal equilibrium, this breast enlargement develops. On examination, the breast tissue feels firm, rubbery, and forms a disc-like mass directly under the areola. It is often bilateral, often symmetric, and in early stages it may be tender, sensitive, uncomfortable. This is different from simple fat accumulation in obesity, which is called pseudogynecomastia. That is adipose tissue, not glandular proliferation. Gynecomastia is relatively common during puberty. In adolescence, it is usually transient, self-limited, physiological. Some men also develop mild gynecomastia later in life, especially after the age of 50, when testosterone levels decline and hormonal balance shifts. But this breast enlargement can also signal systemic disease, can reflect endocrine imbalance, can reveal internal pathology. It may indicate liver cirrhosis, sometimes a testicular tumor, sometimes hyperthyroidism, and sometimes medication effects. Rarely, it may even represent male breast cancer. The fourth sign is Acanthosis nigricans. It appears as dark, thickened, velvety skin, most commonly on the back of the neck, the armpits, sometimes the groin, sometimes under the breast. It is not dirt. It does not wash off. It is not a fungal infection. It is a metabolic sign, a hormonal signal, a cutaneous marker of internal imbalance. Acanthosis nigricans develops because of chronically elevated insulin levels. This persistent hyperinsulinemia acts not only as a metabolic hormone but also as a growth factor. Insulin stimulates insulin-like growth factor receptors, activates keratinocytes, the surface skin cells, and fibroblasts, the structural cells of the dermis. This leads to increased cellular proliferation, increased skin thickness, and enhanced melanin activity, producing the characteristic velvety, hyperpigmented, thickened plaques. Acanthosis nigricans is strongly associated with obesity, with type 2 diabetes, and with polycystic ovary syndrome. In most cases, it indicates at least insulin resistance, often metabolic syndrome, and signals an increased risk of future cardiovascular disease. The fifth sign is petechiae. Petechiae look like small purple or red dots, usually up to 2 millimeters in diameter. They are flat, and they do not blanch when you press on them. This is a critical difference. If you press a normal red rash and it turns pale, that is simply vasodilation, blood still inside the vessels. But if you press on petechiae and nothing changes, it means blood has leaked out of the vessel. It is a microhemorrhage, a tiny but real bleeding into the skin. Why does this happen? Every day, small capillaries are mildly injured. This is normal, but platelets immediately adhere to the damaged endothelium, stick to the injured vessel wall, form a plug, and stop bleeding within seconds. The system is fast, precise, protective, and the skin looks normal. But when the platelet count is low or platelet function is impaired, this mechanism fails. Capillaries leak, microbleeding occurs, and these non-blanching red dots appear. It most commonly occurs in thrombocytopenia, particularly in immune thrombocytopenic purpura, which is an autoimmune disease where platelets are destroyed by the immune system. It is common in children after viral infections and also seen in young women. It may also appear in cases of bone marrow suppression, such as leukemia, aplastic anemia, or during chemotherapy, when platelet production is reduced. In severe infections like meningitis, especially meningococcal meningitis, petechiae can be a critical and urgent sign. The sixth sign is purpura. Purpura appears as larger purple or dark red patches under the skin. It is bigger than petechiae, usually between 2 millimeters and 1 centimeter. It also does not blanch when you press on it. If the lesion becomes larger than 1 centimeter, it is called ecchymosis, which is essentially bruising. So the distinction is clear. Petechiae are tiny, purpura are intermediate, and ecchymosis are larger areas of bleeding. Like petechiae, purpura results from blood leakage outside the vessels. But why does it happen? It can occur due to platelet disorders, just like petechiae. Low platelet count or impaired platelet function allows capillaries to leak, but purpura can also occur because of blood vessel wall inflammation, known as vasculitis. When the immune system attacks small blood vessels, inflammation damages the vascular wall, and blood escapes into surrounding tissue. This produces what is called palpable purpura, and this is clinically important. If you run your finger over the lesion and it feels raised, think about vasculitis, not just a platelet problem. Raised, inflamed, tender. This suggests vessel inflammation. Most commonly, this type of purpura is related to autoimmune disease. It may also occur due to drug reactions, medication-induced hypersensitivity, or certain infections. A classic example is immunoglobulin vasculitis, previously called Henoch-Schönlein purpura. It is more common in children, often occurring after an upper respiratory infection. It is mediated by immunoglobulin, a deposition in small vessels. The purpura typically appears on the legs, sometimes on the abdominal wall, and is often accompanied by joint pain and abdominal symptoms. In the elderly, there is another form, senile purpura. Here, the skin becomes thin, fragile, and collagen weakens. Minor trauma causes bleeding into the skin. This is not a clotting failure, not an immune attack, but a structural fragility of aging tissue. Seventh sign is ecchymosis, what people simply call bruising. Ecchymosis is larger than 1 centimeter, flat, discolored, and typically changes color over time, blue-purple, then green, then yellow. as it gradually resolves. It often happens when a person bumps into something, a table, a chair, a door, and small capillaries rupture. Platelets activate, a clot forms, and healing begins. This is normal physiology, normal hemostasis, normal repair. Occasional bruising after clear trauma is common. But easy bruising without trauma is different. When a person says, "I don't remember hitting anything," or bruises simply appear, this suggests an underlying problem. In these cases, the cause usually falls into four main categories: platelet problems, clotting factor deficiency, blood vessel fragility, or medication effects. First, platelet disorders. If platelet count is low or platelet function is impaired, small injuries bleed longer and bruises form easily. This can occur in severe infections, liver disease, leukemia, bone marrow suppression, or other conditions affecting platelet production or survival. Second, clotting factor deficiency. Disorders such as hemophilia, vitamin K deficiency, or severe liver failure impair the production of coagulation factors. Without adequate clotting factors, bleeding persists longer and ecchymoses appear more readily. Third, vessel wall fragility. This is extremely common in older adults. As collagen declines and the skin becomes thinner, capillaries become fragile. Minor, often unnoticed trauma can lead to senile ecchymosis, especially on the forearms and hands. This is visible bruising with minimal impact, due to structural fragility rather than clotting failure. Fourth, medications. Drugs that affect coagulation or platelet function can cause easy bruising, including warfarin, heparin, direct oral anticoagulants, and even aspirin or clopidogrel. If bruising appears together with nosebleeds, bleeding gums, heavy menstrual bleeding, blood in the urine, fever, or unexplained weight loss, this is not cosmetic and not trivial. These are red flags, especially if bruising is rapid, extensive, or associated with petechiae. It requires urgent medical evaluation.